Good afternoon, everybody. My name is Marijke from the Division for Research Development at Stellenbosch University. I would like to welcome you to our Stellenbosch Forum lecture series. We've got a theme this year for the series, Changing Climates. So the idea is to address how research can be impactful in finding possible solutions in our rapidly changing settings. And so we include the influences or research around the influences of changing environments associated with natural resources, health, education, history, and economies. And today we will tackle the topic of digitization of healthcare. And I would like to introduce you to Professor Keymanthri Moodley. She's a distinguished professor in the Department of Medicine and director of the Center for Medical Ethics and Law in the Faculty of Health Sciences at Stellenbosch University. The center was designated as a collaborating center in bioethics in 2019 by the WHO, only one of 12 in the world, and the first on the African continent. Professor Keymanthri is also an adjunct professor in the Department of Social Medicine, at the University of North Carolina, Chapel Hill in the USA. She's a specialist family physician, a bioethicist, NRF-rated researcher, and a member of ASAF. To date, she's been awarded grants to the approximate value of 68 million, which is astounding. And the center has also trained 40 mid-career professionals from 10 African countries in bioethics and currently has 8 PhD trainees. She also serves on the Scientific Advisory Committee of the EDCTP, and her most recent NIH-funded research project explores ethical, legal, and social issues in data science innovation in Africa. And the topic, therefore, of today's talk is very appropriate. Professor Moodley, thank you very much for your willingness to participate in our forum lecture series, and we look very much forward to hear your talk. Thank you.
Good afternoon, Marijke, and thank you very much for the introduction and for the invitation to speak at the series of lectures. I'm going to hope that technology doesn't let me down today. So please confirm if you can see my slides on your side.
It was there a moment ago, but I think you just need to share again.
Okay.
It's loading at the moment. There you go.
Okay, so thank you so much. And I think today we're going to look at how healthcare is changing. And in many respects, I mean, there's always been a level of change within the discipline of healthcare. As you all know, medicine is founded on a very human interaction between healthcare professional and patient, and dates back centuries to the very early days when physicians like Sir William Osler described medicine as a science of uncertainty and an art of probability. So for many, many decades, the intersection of art and science within medicine has been a very important concept. And the human interaction with patients has been, the cornerstone of healthcare in many respects. Despite this, over time, there has always been a need to introduce technology. And as you can see, in the early 1800s, healthcare professionals, many of whom were mostly male, had a very uncomfortable way of examining patients and used physically the human ear to listen to the heart, requiring extremely close contact between doctor and patient. If you look at this particular scene today, this would be interpreted as some form of sexual impropriety with respect to patients, and would be frowned upon. However, this is where, the art of medicine actually started. But the healthcare professionals themselves became uncomfortable with this method of diagnosing illness in patients, or examining patients for that matter. And it was in 1820 that Dr. René Laennec developed a wooden stethoscope. So he started off with a piece of paper, that he folded into the shape of a tube to try and hear what the heart sounds, and to hear how people were breathing, and then found that it became necessary to transform this into a wooden instrument. And it was only in 1852 that two other physicians worked towards developing what we today know as the stethoscope, which is quite today, over the years has advanced and improved, and has become quite important in terms of diagnostics. So as we have, as we progress, it becomes quite important that we can see development happening within the field of healthcare. Of course, all of this has been accelerated by artificial intelligence. And we know that in terms of development of AI, this has happened decades. It started decades ago. John McCarthy is accredited with having contributed significantly to coining the term artificial intelligence and to developing much of the theory around it. And for this, he received the Turing Award in 1971. Now, what he said was, whatever a person can do, he should be able to make a computer do for him. For many people who have the tasks of cleaning their floors and windows, for the many home executives and domestic workers, I think we all welcome the development of technology and AI in the form of robots to clean our floors and robotics to help us clean our windows. So clearly, where AI is concerned, life can be significantly improved in many different ways. If we look at a hospital in Singapore, Shiang Hospital, since 2015, has already implemented the use of robots for operational tasks around the hospital, such as delivering meals to patients, delivering medicines, and assisting in various ways with operational tasks and logistics within healthcare systems. But robotics have entered into the space of the doctor-patient relationship in more ways than one. And we can see more and more developments occurring on a daily basis. Now, during the COVID pandemic, I think we were all exposed and made more aware of the critical role of AI in healthcare. One of the challenges we faced very early on in the pandemic was the fair distribution of limited resources throughout the pandemic. And although it started with things like PPE and other supplies, it soon became an issue in terms of ICU care, access to ventilators, which patients would be able to have access to ventilation, and which patients could not be admitted to an ICU. Now, the reason for this was clearly limited to reduced supply and increased demand. During the pandemic, it was nothing new for South Africa. We know in our healthcare systems, we've always had a crisis in terms of adequate resources and limited supply of dialysis machines, of ICU beds, of ventilators, are part and parcel of being a health professional in this country, and learning how to distribute these resources fairly is something that is part of medical training and part of ethics training as well. And in order to do this, in order to distribute limited resources fairly, it's often necessary to have specific criteria to follow and to be as objective as possible so that patients are treated fairly. And we knew there were a number of triage systems that were in place during the pandemic. Um, and doctors struggled. Doctors and nurses in ICU settings really struggled because it was difficult to deny patients access to care when they needed it, especially when almost everyone being referred to an ICU at the time really needed to be on a ventilator or really needed to have critical care services. Sadly, it was not possible to give this level of care to everyone, and many healthcare professionals developed moral distress around the need to choose between their patients. As a result, a number of triage committees were established with independent people, doctors, ethicists, and others who could assist in making these difficult decisions to ensure that the ICU doctors and nurses, were spared some level of moral distress. And this is where an application of AI became really important because people started to develop triage algorithms based on machine learning that could actually help to make those decisions for healthcare workers. And in some settings where this occurred and where research was conducted, it was found that these machine learning triage algorithms were able to choose or select patients as well as a triage team of healthcare professionals. As long as one used extremely objective criteria, an algorithm can actually assist in triage and in choosing patients for specific resources. This is it remains a very controversial area because we know that it's not always extremely objective scientific factors that can be used. The experience of healthcare professionals in understanding prognosis and understanding patients and their chronic conditions, etc., also guide decision making in terms of which patients have a better prognosis and may do better in an ICU or on a ventilator. And so while algorithms do offer a considerable advantage in helping with triaging, they may not be foolproof all the time, but we can speak more about that later. Another very common gadget that we all became familiar with during the pandemic was the pulse oximeter. I think most households in South Africa had a pulse oximeter of some sort. During the pandemic, people learned how to use them, and we knew what levels of oxygen saturation were danger levels, when people needed to go to a hospital or seek medical attention, etc. So it was wonderful that people were interacting with medical technology in their own homes. The only problem with the pulse oximeter was that it was built based on collection of large amounts of data, but somehow appeared to have both racial and ethnic bias in terms of how the oxygen level was detected in people of darker and lighter skins. So based on the science used in making the oximeters and the data that was fed into the system, what happened was that in many of these devices, they underestimated oxygen levels in people of color. So if a person of color had a lower oxygen level, needing more urgent treatment, the oximeter was reading at a higher oxygen level. So in some respects, this was misleading, and it could have led to some patients not receiving a treatment in time and according to their need where oxygen was concerned. And so this concept of bias in artificial intelligence is a really important one, also very well documented in this book on invisible women that speaks about big data and bias in data and how historically many clinical trials, many research projects have enrolled more men than women. And have enrolled perhaps people of different ethnicities that are not representative of the ethnic variety we see in society. So this level of bias is detrimental to how algorithms can function, and we need to be really wary in terms of how we interpret data, how we conduct research, and we need to ensure that there is always diversity in terms of our study population when we are involved in research. So when I was a medical student almost 30 years ago, we had lots and lots of textbooks, anatomy, physiology, etc. And many of the studies we read were all based on the 70-kilo white male. And so we can see that historically, healthcare and medicine has got a huge amount of bias in terms of data collection and in terms of the type of data that we have collected over decades. So there's lots of talk about big data and AI. And I think there's a very important relationship between big data and AI. So we know now that over several decades, huge amounts of data have been collected in research, in health environments, and in other environments as well. So sources of data are really interesting, especially as we all become more techno-savvy. So we have cell phones and we have wearables, and all of these pieces of technology are constantly collecting data, whether we're aware of it or not. And when we purchase our cell phones, we sign terms and conditions in which we agree to have our mobility data collected, to be monitored in various ways, and for our data to be shared. When we sign up for medical insurance, we also acknowledge in the application form for medical aid that we agree to collection of our health data and to sharing of that health data, usually in an anonymized form, but we agree nevertheless. We don't specifically consent to it, but we kind of accept it when we apply for medical insurance. And so when we purchase an Apple Watch or any other wearable, we monitor our step count for the day, but that data is being collected somewhere centrally and is being housed in huge data banks. Of course, huge amounts of data are necessary for artificial intelligence, but there are a number of ethical, legal, and social issues that are linked to big data collection, and I will discuss this a little bit more just now. And so artificial intelligence is really important in healthcare. We know that AI since the 1950s has been well developed, where computers perform tasks that are usually performed by humans. We know that machine learning is an application of artificial intelligence, and it is focused mostly on how computers learn from data. So when we talk about big data, we need huge amounts of data to be fed into systems to allow for computers to learn from that data. And so machine learning sits at the intersection of statistics and computer science. Now, that's not my area of speciality, but there are many people on the webinar who know better than me, like all the people from the School for Data Science. And so the details of that, I'm sure are explained and taught in other settings as well. But for our purposes, I think we just need to understand where these various terms belong in the big scheme of things, and that in addition to machine learning, there's the concept of deep learning, and that too is really important, and that the way computers learn from big data is an iterative process by feeding data in and refeeding data in until computers repeatedly over time learn to develop algorithms in ways that enhance human health. So we know that computer scientists build software models that simulate the learning models of the brain, and these take the form of various neural networks that simulate the neurons that we have in our brains that are responsible for human learning. So extremely complicated, and I'm still wrapping my brain around all these technicalities around artificial intelligence. But it's going to take a long time for all of us to be up to speed with exactly what happens in that black box world that we may not necessarily be a part of. Now, everything about data collection and research in healthcare is linked to the concept of precision medicine. And this is an important approach to disease treatment and prevention, where we look at individuals, we look at their genetic makeup, environment, and lifestyle, and try to tailor make treatments to suit individual people. And in this domain of medicine, all forms of data collection and AI are really important. Now, in various aspects of healthcare, AI has developed significantly, more so in those disciplines that depend on images. So, for example, a dermatologist looks at the skin and makes a diagnosis based on how a particular rash would appear. And pictures of these different types of dermatology conditions can be fed into computers. Algorithms can be developed. You can see at Stanford University, they collected 130,000 images of 2,000 different skin diseases, built an algorithm, tested this algorithm against the diagnoses made by actual dermatologists, 21 different dermatologists, and found the algorithm and the machine learning application to actually be more accurate than the dermatologists. Similarly, in the field of radiology, where X-rays are read usually by human doctors, when we take data from X-rays and feed them into an algorithm, the diagnostic precision of AI can exceed that of the radiologist. And so there are huge implications for how much more quickly diagnoses can be made from X-rays and other images that are used to help medicine. Similarly, in rheumatology or patients' diseases affecting our joints, we know that a great deal of patient education has to occur. And so IBM Watson has developed chatbots that help with patient self-management. And so the use of these virtual assistants help to enhance the role of the healthcare provider by assisting patients after hours and giving advice and reminding patients about their medication, etc., helping tremendously in health education. So all types of wearables can help in rheumatology. There are also ingestible sensors that can tell us whether patients are actually taking their medicines or not. And, adhering to medication and compliance in healthcare is a huge challenge. And of course, there's genetic sequencing, where we can sequence people genetically and use biomarkers to develop personalized treatment for different people who have the same disease. So huge amounts of advances and possibilities in terms of prediction, monitoring of patients, and diagnosing patients. What is very interesting about data and who owns it is that there was a time traditionally in healthcare when doctors kept all the data or hospitals kept all the data. And we are now moving towards a scenario where patients are able to keep their own health data, collect their own health data using all kinds of wearables and portable types of diagnostic devices. And so we are moving towards a more democratized type of healthcare where patients and doctors have access to health data that was not the case previously. Even in terms of genomics, we know that there are various commercial companies like 23andMe, where there is direct to consumer interaction. So one can provide a sample, send it to the United States, and get a sample that you take by scraping the inside of your cheek, send some cells across to 23andMe, and they can run a full genomic screen and send it directly back to the person without a healthcare provider being involved. So this level of change in healthcare is something that is really interesting, but also extremely controversial, because there is so much data that is being given to patients and so little counseling associated with it, that the type of counseling one usually gets from a healthcare provider, the type of guidance one usually gets from a healthcare provider in terms of which results to take seriously, which results not to worry about, and which results to share with other family members. That is the type of additional human service that one tends not to get when one works with direct to consumer companies, etc. And so we return to this important phenomenon of the relationship between big data and artificial intelligence. And so I said earlier that in order for us to build algorithms, we need to collect huge amounts of data. We collect this data from various sources. But because there is so much data out there, one also needs governance frameworks. And so there are huge advances in terms of data protection legislation and how we can protect the data that we collect. So in South Africa, I'm sure you've all heard about the POPI Act, and it was fully enforced last year. And what is really important about the Act is that it attempts to balance the right to privacy, which we all have, with the right to access information, but also to the right to freedom of expression. So we have a right to our privacy, but there is also the aspect of public interest where data needs to be collected to ensure that there is some common good that comes out of the data that is collected. For those of you who've seen the movie The Circle, you will know that when we speak about privacy, there is an interesting spectrum, and we can operate on the spectrum from a position of absolute privacy where none of our information is shared with anybody, which is really quite impossible nowadays, to the opposite scenario where we have absolutely no privacy and all our information is out there. And today, I think we often get the feeling that we have no privacy, because we know that when we speak, even our cell phones are listening to what we say. We know that our mobility is monitored. When we switch on our apps like Google Maps to travel from point A to point B. So where we are and what we're doing is almost constantly monitored. And although the movie The Circle was made to show us what a world would look like if there were no privacy, I think we are moving closer and closer to that scenario where we don't really have all that much privacy. So we know with respect to data, it's an attempt, the POPI Act is an attempt to protect our data. Of course, if we use de-identified information that cannot be re-identified again, then that type of research falls outside of the POPI Act. Or where deceased persons' data is concerned, that falls outside of the POPI Act. But there's a lot that actually falls within the POPI Act, and that a lot of information that is protected. And here we know where healthcare is concerned, biometric information is regarded as special personal information. And biometric information includes our blood types, our DNA analysis, fingerprinting, retinal scanning, voice recognition, etc. All of which is really important in different types of technology today. Now, the POPI Act has lots of implications for medical research in terms of data sharing, security, storage, training, etc. And the Academy of Science of South Africa is working on a code of conduct that will help to explain to researchers how our data can be used, stored, shared, protected, etc. So there's a huge ethical discussion around aspects of data sharing, the consent that we take from people when we collect data. So for example, within the healthcare system, if we are going to collect our patient data and store it or share it with others for research purposes, then patients need to consent to this. So we know there are many developments. For example, in the Western Cape, we now have a provincial health data center in our public hospitals. And so it's really important that there is considerable patient engagement so that patients are aware that their health data is being collected. As things stand, we're all using paper records for healthcare, but in institutions that have electronic health records, then the collection of data happens much more quickly, and sometimes patients are not really aware that their data is being collected and that it will be shared for research purposes in the future. There are questions around who owns the data, who owns our biological samples, like blood samples that we give in various research settings or in hospitals. And there are questions around how this is all commercialized. Of course, that is a material for a whole other discussion, and I'll touch on some of those points a little later on. But if we come back to the healthcare environment and look at the way AI and technology is changing healthcare, we need to look very briefly now at some of the ways in which healthcare is being transformed. So we all know that diabetic patients often have to monitor their own blood sugar levels. And if you're on insulin, you have to do this more rigorously. And it often requires a little finger prick and a blood test, etc. But technology and developments can lead to improvements in how blood sugar monitoring occurs, for example. So having a sensor built into a contact lens that is worn in the eye can help to monitor blood sugar levels without patients having to constantly prick themselves. And for some, this is going to be a remarkable development and will significantly improve healthcare. We know that in many scenarios, there's the possibility for robots to interact directly with patients. Now, as things stand, we don't have fully automated systems in healthcare where robotics is concerned. So there is always still a human involved in the interaction between patient and robot. But in the future, we would be moving towards a more automated system where AI is in existence in its actual format as an artificial intelligence format that could exclude humans. As things stand, we are not there yet. So in terms of the law and the robotic doctor-patient relationship, there are lots of issues to consider, especially issues around medical liability and what goes wrong. What happens when things go wrong with robotics and other forms of technology? Again, another discussion entirely on its own. I think a big question that we have to ask is, we've all been familiar with the doctor-patient relationship. Many patients develop trust in their healthcare provider over years and years. And, will have a particular operation performed or will go to a specific doctor based on trust in the ability of that doctor, based on trust in the competence of that human doctor. So at what point will patients actually decide that they can trust something else, something other than a human for healthcare provision? When will patients decide that they can trust AI because it's going to improve their diagnosis and treatment? And so one example of new technology in healthcare is the Vinci Robot, which you may have read about in the newspapers. And this robot is being used at Grootskloof and Tygerberg hospitals as two big public hospitals, where some forms of colorectal surgery and some forms of gynecological surgery are being done using the robot. And as you can see in this picture, it's quite a big robot, but in the corner, there's a computer screen and there's a doctor, and there is a surgeon actually controlling the robot and the operation throughout the process. So it's not a fully automated process, and there is still human interaction. So it is robotics augmenting the work of a surgeon. Clearly, a very interesting and important development, a very costly development, as we know, because the Vinci Robot costs just under 40 million rand, and it has a whole host of consumables as well. And so many important considerations in terms of cost-benefit analysis, and of course, a number of issues around risks that may be involved where robotics are used in healthcare. So it's not surprising that the World Health Organization has developed a set of guidance on the ethics and governance of artificial intelligence for health. And it's a very, very detailed guidance document, and there are many aspects to consider. And so within the short space of time that we have left, I'm going to look at just some of the important principles around AI and ethics. And protecting human autonomy is an important principle because patients need to be in control of their own healthcare decisions. And so it's really important that there are consent issues that are addressed and that patients understand the different aspects of care when robotics are used or when artificial intelligence is part of their treatment or diagnosis. Taking data from electronic health records, collecting data from research projects to develop algorithms is an important development, but throughout the process, it's important that patients and research participants are aware that this is happening. Also really important is that any type of AI should promote human well-being. It must be safe and must be in the public interest. And so here, safety is really important. And so I spoke earlier about the legal aspects around safety and what happens when things go wrong with robotics. If anyone has watched the series New Amsterdam, a medical series on Netflix, and if you particularly watch the Monday evening episode this week, season 4, episode 8 to be precise, you would have noted a horrific scenario depicted on the program where there was a cyber attack and a ransomware virus, attacked the entire hospital system, which impacted on various forms of AI that were being used in the hospital, including robotic surgery. So I'm sure with all television programs, there's a degree of poetic license, but one needs to know exactly whether this can or cannot happen. And so as part of consenting patients who are going to receive robotic surgery, it's important that risks are fully explained and that safety is also considered in these discussions. So transparency is really important. And then the concept of explainability. And we all know that everything about AI, big data, machine learning, neural networks can be complex. But it is important for us to understand how these various technologies work and to be able to explain it to patients so that they can make informed decisions about the types of surgery that they choose to have. And so in addition to being transparent, to being able to explain away all these important concepts to patients, we also need to ensure that there is responsibility and accountability. And this is important because there are many developers involved. So there are different role players in healthcare now compared to what there used to be before. There are a whole host of companies making robotic instruments and other types of wearables, other types of diagnostics, and all these developers, AI developers, need to be held accountable as well in terms of safety. And so accountability is important. Inclusiveness and equity in South Africa and the rest of the African continent is important because we already know there is a digital divide and that everyone does not have equal access to the internet, to new technologies, to AI, to training of surgeons, for example, who are able to do robotic surgery. And so equity and ensuring everyone has access to advancements in healthcare is important, especially as we progress towards the ideal of ensuring access of healthcare to all. Of course, any type of AI that is developed must be both responsible and sustainable. In terms of sustainability, there's an important relationship between AI and climate change. Again, a talk for another occasion. But whatever AI mechanisms are developed to enhance healthcare, we also need to ensure that they are friendly to the environment and will not exacerbate the climate crisis that we currently have, and that also impacts negatively on healthcare. Now, I'm sure many of you heard about patients during the pandemic. And so while there are amazing developments taking place in a positive direction, we know that during the COVID pandemic, there were many, many patients who died alone, who did not have family and friends nearby, who could not have other people in the ICUs or in the hospital wards. And so some institutions, including Tygerberg Hospital, had developed a little robotic device that could help patients communicate with their families. But there are even more advanced technologies like virtual reality and holograms that can help patients who are at the end of their lives during pandemics where patients, family and friends may not visit. And so in this respect, there are many advances still to come. We've learned a lot during the pandemic about the importance of technology and AI. We've all been using apps, contact tracing apps, etc. And we know that there is an important role for technology and AI when there are public health crises and emergencies. But in all of this development, it's really important to ensure that the ethical issues are taken into account, that the legal frameworks are developed, and that there is adequate public engagement so that people understand the impact of AI in healthcare. In terms of how we train our medical students, there are many implications, and we need to develop a healthcare workforce that is data literate, that understands AI and machine learning. And so the School for Data Science and Computational Thinking has a huge role to play in terms of educational programs for students across the board, including health science students. We need to know that as much as we commonly use the term AI and refer to it as artificial intelligence, at this point in time, it's more a type of augmented intelligence that is helping humans within the healthcare sector and other sectors to do their jobs better. Acknowledging the importance of data science for health discovery and innovation in Africa, the NIH has developed a very big research project that currently has 7 different research hubs and 4 groups looking at the ethical, legal, social issues around data science and AI in Africa. And we are very fortunate to be one of those ELSI groups exploring the various ethical, legal, and social concerns linked to data science and AI in healthcare. And so it's this type of scholarship and research and further reflection that will help us to develop guidelines and governance frameworks to ensure that as technology advances to improve health, we are also mindful of all the ethical, legal, and social issues that are an integral part of any type of development in healthcare and in science. I'm going to stop now and thank you for your attention, and I'm happy to take a few questions.
Thank you, Prof. Moodley. Definitely, you've given us a lot to think about. It's a whole new way of thinking, very interesting. It raises a lot of interesting issues. I would like to open the floor for anybody who would like to comment or ask a question. You can either raise your hand or you can also write in the chat. We're happy to take any comments or questions. Kanshu, thank you for raising your hand. I was actually just about to pick on you to ask if you've got any questions or comments. So very, very appropriate that you've raised your hand. Over to you. Welcome. Thank you.
Thank you, Marika. Thank you, Professor Moodley, for a really interesting talk. Much appreciated. So I guess my question has to do with, in any of these aspects, there is no, proper governance structure on ethics, right? Forget about AI for a moment, just in general. At the medical school, if you do research at the medical faculty, at least there's an ethical, what do you call it? The people who check your ethics.
The Research Ethics Committee.
Yeah, REC, that's it. But when you're developing new AI tools, etc., I'm not talking necessarily in the medical field, but anywhere where it interacts with humans, we don't always have an ethics committee in firms that ensure that things are ethical. So what can be done what do you think can be done from like a government or legalistic point of view to ensure that people do behave in an ethical manner? Because one of my worries is that, that the laws haven't caught up to necessarily AI advancement. Thank you.
So thank you for that question, and it's an excellent one. And we are still, I think, very much in the early phases of development where governance frameworks are concerned. Now, the research ethics committees that you mentioned are very familiar with regular research, but when it comes to doing research with large volumes of data, using databases, etc., the guidelines have not yet been updated. And so some of the groups that have been funded by the NIH to look into these issues are starting to do capacity development workshops. We have one planned for the end of October, and we are conducting research in sub-Saharan Africa, looking at both research ethics committee members as well as researchers and data scientists, and hoping that with our empirical data, we can work towards developing these governance frameworks and guidelines that hopefully will be adopted by the National Health Research Ethics Council, and that government at a broader level will take AI more seriously, because it does not affect the healthcare profession only. There are implications for computer scientists, for data scientists, for private companies that are developing robotics, etc. And there are many, many questions, not only around research ethics committees, but also around our regulatory body. So in the United States, there's the Food and Drug Administration, or the FDA, that approves drugs and devices. But in South Africa, our South African SAHPRA, our regulatory body, approves drugs only, or vaccines, or devices, not really medical devices. So the question is that when we are using robotics in South Africa, are we using it based on the FDA approval? And is that good enough for the South African setting? Or on the continent at a broader level, so in terms of the CDC and the African Union, there are also implications for the type of regulatory structures that need to be established in order to ensure good governance. If we look at South Africa, we have clinical ethics committees in some hospitals who also will be keen to understand how robotics are working within their hospitals. What consent is taken when data is collected in public hospitals? Are patients even aware of this data collection, and have they consented? So there's a role for clinical ethics committees to play in hospitals. There's a role for research ethics committees to play, but there's also the role for important other committees to be established, such as data access committees and committees looking more specifically at big data and AI, which currently do not exist. So as part of our project, we have an ethics advisory committee, but it is currently linked to the project that we are working on and not broadly available throughout the country. So loads of work still to be done in terms of governance and ethics. Thank you.
Thank you,
Professor Moodley.
Thanks, Kanshu. Vim, I see your hand. I just want to first deal with a question in the chat. It's from Mrs. Inglis Yassin. And the question is, how do we prepare and build awareness and capacity in our clients/patients to benefit from these advances in healthcare in our local context, where basic and health literacy remains poor?
Mm-hmm. So again, I mean, that's such an important question. And throughout healthcare, we've always had this problem about how much we engage with patients. We know that in public hospitals, patients sit in waiting rooms for hours and hours, and often nobody engages with them. Nobody talks to them. There are no videos playing to improve literacy where health is concerned. During the COVID pandemic, we had a lot more engagement. We had television programs, and we had the president coming on every few weeks to talk to the people, and lots of other types of engagement happen, but not enough. Where data is concerned, we need to do a lot more work in terms of engaging with the public through media. We need for scientists and health professionals to write more for the lay media so that the messages get out there. We need to find ways of using social media, which we know is so popular with the public and with everybody, to use it in a positive way to ensure that good messaging occurs and that good information is shared, unlike what happened during the pandemic, where a lot of misinformation was transmitted. So there's a huge potential for engaging with the public to ensure a level of data literacy. Not only the public, but also different professional groups that may not be that familiar with issues around data. Thank you.
Thank you so much. Wim Delva, over to you.
Good afternoon. Thank you so much for a really great lecture. Would like to ask a question around the training of medical students. And I have 20 questions, but I'll try to keep it short. So I guess at the core, what I'm trying to understand is what's the strategy, if you know, for bringing that into the curriculum? I'm sure there's a lot of pressure from all sorts of lobby groups who say, oh, but they should know more about this and that, and AI is only one of many such lobby groups. And also, what's the appropriate timing? What's the appropriate volume? I guess there needs to be some kind of national coordination, that the curriculum isn't just, universities can't just do their own thing. So what's the plan? And then lastly, as you may know, I was part of Stellenbosch University for many years. I still am, but no longer on the payroll. I run a data science company that focuses on data science in health. Do you think there would be a potential role for us to contribute to that curriculum? Because that's something that's very near to my heart. Thank you.
I'm so glad you raised this question. We just had a very big data science workshop at our faculty. There are people on the call who were part of this workshop. Prof. Rajaratnam was one of them, and Prof. Bruce Watson, the School for Data Science, was well represented. And we started to workshop over 2 days these very questions that you raised, in terms of how is it going to impact on research and how is it going to impact on the curriculum. And at the end of the 2 days, there were task teams that were formed specifically to look at how we can include data science training within the medical curriculum. As you know, our health science, well, our medical curriculum is being completely revamped at the moment. And so it provides a very good opportunity to embed data science training in a longitudinal and horizontal way throughout the 6 years of training of our medical students. There are also postgraduate students who require training in this respect. So huge opportunities. And if you would like to be involved, please contact the School for Data Science or Prof. Nico Gay van Pitius, our Vice Dean of Research, who is leading this at our faculty. And we'd love for you to be involved, because public-private partnerships are really important in the field of data science, simply because there's so much development happening in the private sector, and the ethics of responsibility, governance issues need to be addressed across both public and private sectors.
Thank you very much.
Thank you. And indeed, as Wim has mentioned in the chat as well, this is sometimes one of the unintended consequences of these lectures, is that it actually initiates further, networks and discussions around collaboration. So that's great. Brunel Bekes says the pandemic showed us the value of mass media to educate the public in a very short time. Posters on lampposts, ads on the radio, local newspapers, TV campaigns, pop-ups in news feeds, etc. So that is indeed so. We've got another follow-up question, I think, from the colleague who previously also posted. She says access to healthcare and the digital divide in rural areas are affected by barriers such as resources and infrastructure. Do you agree that intersectoral collaboration is needed to gain maximum benefit for health and well-being? And then she would appreciate your thoughts on how we ensure that everybody or everyone is at the table, including end users and stakeholders, and including policymakers, patients, and communities.
I think that's critical. I mentioned the digital divide earlier on, in terms of high-income countries, low-income countries, but I think within South Africa and other low to middle-income countries, the divide exists between various different socioeconomic groups and between urban and rural communities as well. So in order to get everybody on the same page, we need to ensure that everyone has access to internet, Wi-Fi, digital technologies, that cell phones become cheaper and cheaper. I think they're just becoming more and more expensive. And to ensure that everyone has access, and it's the new currency of communication and interaction in the world, and nobody should be left behind. So we need to look very imaginatively at how we can do this properly. There are important concepts like the fortune at the bottom of the pyramid, where people economists developed approaches to ensure that we could find ways of reaching those who are the poorest in our societies, and by packaging information in ways that are appropriate to reach that base of the pyramid population, which is where the majority of the population sits in many countries, and to ensure that they have access to technology and to technological devices as well. So it's about corporates thinking more creatively about their social responsibility in terms of how they can uplift communities by providing services like the internet, simple access or easy access to services in all communities. I would love to hear if you have other ideas as well.
Thank you, Prof. I don't know if do you want to respond to that? Ms. Inglis Yassim, she says here, thank you, Prof. Moodley, for a thought-provoking and informative presentation, and also for your responses and feedback. I see we've reached almost the end of our time for this lecture for today. If there are no more questions, or she says she cannot unmute at this stage, but I'm sure you can catch up after the talk. There's one more question, and I think that will be the final one that we deal with. It asks, does SUN's medical school have a course on medical anthropology? This discipline needs to feature more in research involving AI and health to avoid racial and cultural bias.
So the new curriculum has been implemented only from this year. Our first year students this year have had a whole different range of courses, and there is more emphasis on medical anthropology than previously. I know I trained at the University of KwaZulu-Natal 30 years ago, and we had medical anthropology classes then, which helped a lot but we also had more diverse classes 30 years ago. Stellenbosch University is catching up, and the diversity is improving. So students are also learning from themselves, from their classmates, because there are so many different cultural groups represented now. unlike in the past. But the need for more deliberate engagement in terms of culture, ethnicity, values, different systems of understanding. In our ethics curriculum, we introduce African philosophy and discussions and debates around those concepts. I think the pandemic was really useful because it highlighted the importance of the public good. It highlighted communal thinking, and it moved us away from being obsessed with individual rights. And it showed us that there is a place when sometimes individual rights need to be limited in the interest of communities. And so there were lots of important learnings that came out of this, but we all I think at Stellenbosch University need to be culturally sensitive and need to engage with issues around ethnicity, gender, in a more meaningful way, and we really haven't done enough of that yet. And in terms of inclusion, I think in research, it's really important to ensure diversity. And research ethics committees also play a very important role here in terms of interrogating the type of study population that is being involved in research projects and asking the questions of who is being excluded and why. So it's often for convenience. For issues around language, for example, people will exclude certain populations. But we have translation services, and we need to use that. And we need to make sure that research is accessible by all who live in the country. Thank you.
Thank you for that, Prof. Moodley, and then thank you, Whitney, also for posting the information about the undergraduate module in the arts faculty, the social anthropology module around medical anthropology. I think with that, thank you so much, Prof. Moodley, again from my side, from the division side. For us, it's a privilege to facilitate these lectures and to also make the research of our excellent, staff members accessible to a broader audience, and to also be able to show the impact and relevance of our research activities to the benefit of society. So thank you very much for sharing your insights with us today. I'm sure, as many people have also indicated in this in the chat, that it's really been thought-provoking and inspiring, and I'm sure you'll receive many emails perhaps afterwards with more questions and opportunities also for further discussion. With that, I would like to thank everybody who attended. You are now on our distribution list, so look out for future invitations to this lecture series, but also to the other opportunities offered by the division to get our research out there and to communicate and to interact with you as our colleagues and our partners at Stellenbosch University. Thank you very much.
Thank you, Marika. Thank you, everyone, for joining and for the wonderful questions.
Thank you.